Good morning. Good morning. We have a lively group today. That's wonderful to hear. Thanks for being here. My name is Holly Brenner. I'm the Vice President of Strategic Development and Marketing for our system. I appreciate that you're spending your morning with us. We've got a promising presentation today, lots to learn. But we'll get started with a reflection. And since we are so close to St. Patrick's Day, we picked an Irish blessing to share with you. May you always have work for your hands to do. May your pockets hold always a coin or two. May the sun shine bright on your window pane. May the rainbow be certain to follow each rain. May the hand of a friend always be near you, and may God fill your heart with gladness to cheer you. Kind of a cheerful one, I think. Huh? Yeah. Today we're fortunate to have with us Dr. Nash. Dr. Nash is one of our otolaryngologists with the Fond du Lac Regional Clinic, and we also have Nicole Auxier, thank you. And Nicole is one of our audiologists, doctors of audiology, also with the Fond du Lac Regional Clinic and Agnesian HealthCare. So they're here to talk to us a little bit about how the relationship between ENT and audiology. So with that, thanks for being here today. Dr. Nash, you can get us started.
I'm going to use this. Thank you very much, Holly, and thank you very much for having us here today, and thank you all for being here. So our goal here today is to kind of give you a little bit of an overview of what we do in our otolaryngology department and in audiology as well. And so we'll strive to kind of do that in about the next 20 or 25 minutes for otolaryngology, and we'll kind of transition into some hearing and hearing loss issues as we transition into Dr. Auxier's talk. This is just a word of warning. I have a lot of pictures and a lot have snot and mucus, so if that bothers you, don't leave me a nasty comment or anything. It's just what we do. I have no financial disclosures. So by way of overview, we'll kind of give you an outline of what we do as a specialty a little bit, and then talk about some of the tools of the trade that we use, so to speak, and the instrumentation and our daily office procedures that really help us to diagnose and treat patients in kind of a different way in our specialty. And then we'll kind of go over just some of the most common otolaryngologic complaints and concerns that patients come in with on a relatively daily basis, and some of the technology that we have that aids us to treat and diagnose those patients. And so what does an otolaryngologist do? And they're referred to more formally as otolaryngology head and neck surgeons, but commonly as an ENT physician. In some parts of the world, it's actually otorhinolaryngology, which is a mouthful, but kind of says exactly what we do, ear, nose, and throat. It's the oldest medical specialty in the United States. And so otolaryngologists are trained really in the full spectrum of head and neck, excluding the brain and the eye. And so we treat all of the subsites really as far as medical and surgical care would go. And so that includes things like the sinuses, allergy problems, smell disorders, the range of sinusitis, including polyps, nasal obstruction. The larynx or the voice box, dealing with patients with hoarseness or swallowing disorders, pharyngeal problems or throat problems, including sleep and snoring disorders, and tonsillitis, benign and malignant tumors of the head and neck, including reconstructive procedures, the oral cavity, not including teeth. And of course, ear and hearing problems, including hearing loss, ringing in the ears, eardrum abnormalities, problem with the mastoid bone, and ear infections. And so we rely very heavily on a team approach, because this is a complicated part of the body that impacts a lot of other areas as well. And so we're really very, very lucky to have such an exceptional audiology department that we work with on a daily basis, and really they're second to none in every way. We also interface very directly with speech and language pathologists and physical therapists as well. And I just listed some of the other specialties that we interface with on a routine basis as well, with a gastroenterologist for swallowing problems, reflux disorders, plastic surgery, with head and neck problems and certain types of cancer and nasal reconstructive procedures, as well as oncologists for head and neck cancer patients, which is a really challenging group of patients with very unique needs. And so this is to show basically that this team approach is really very important, because really on a daily basis we have interaction with patients over the wide spectrum of age, really from infancy to geriatric patients, almost every day in our office. So that team approach is really important. Moving on to some of the tools and instruments that we use, we'll talk about binocular otomicroscopy, which is a detailed examination of the ears, and then nasal endoscopy, as well as flexible laryngoscopy, which allows us to see the voice box. And so this is where some of the pictures come in. These are all very brief office procedures that we do every day, very minimally to no discomfort with all of them. We use topical anesthetic for all of these, and patients really tolerate them exceptionally well. And so starting with binocular otomicroscopy, as you can see here, this is the microscope that's used to look in the ear. And what we're seeing here is a completely normal eardrum. And so this is what we're able to see, an ear canal here, an eardrum, which is nice and clear and translucent. And it really gives us a detailed examination really of what's behind this eardrum, or the middle ear space. And you can see one of the bones of hearing right there, which is the malleus. That's the first ear bone, so to speak. And this is a normal picture, and it takes a while to know what's normal actually in clinic for those of you that look at ears. And there's a lot of vessels there, and there's a lot of redness theoretically, but this is a very normal eardrum for a patient. In contrast, these are things that we see every day as well, which are not very normal. So this first one is mycotic otitis externa, or a fungal infection of the ear, which is exceptionally common. You can see the yeast and fungal elements here obviously growing in the ear canal, causing inflammation and pain in the ear canal and hearing loss as well. This is broadly classified as a swimmer's ear type of thing, which is really any external ear infection. This can be caused by Q-tip use and microabrasions in the ear canal, just causing normal flora to become pathologic or become a problem in the ear, but relatively easily treated. The next one is serous Otitis Media, and this, hopefully these are coming through okay, but this is clear fluid, non-infected fluid behind the eardrum, with a really retracted eardrum as well. And this causes hearing loss, so a patient will have fullness in the ear, hearing loss, and pressure sensation. And it's a relatively common problem in both adults and children. And this can certainly happen after an upper respiratory infection or a sinusitis or even a different type of ear infection. This next one's more of a classic ear infection, a suppurative otitis media, which is pus behind an eardrum, red, inflamed, and bulging. Children get this quite often, and this is generally the first line is treatment with oral antibiotics. Moving on, this is, hopefully this is coming through also, but this is a really retracted, or what we call atelectatic eardrum. The eardrum is completely plastered to the underlying structures, and so this patient is certainly going to have some hearing loss and pressure sensation in there, and this is a problem in and of itself, but really why it's a problem is because you can get what's called a cholesteatoma, and it has nothing to do with cholesterol, but this is a collection of skin cells that can develop in one of these little pockets and wall itself off and keep growing, and it causes a great amount of localized destruction and erosion of important structures in the ear. And finally, a hole in the eardrum. It's a panic membrane perforation here, often from trauma or sometimes Q-tip use, and a little scarring here, which is actually a very common finding in patients who've ever had any ear infections before. We also are able to see what ear tubes look like in the ear. So we check kids' ears a lot and adults' ears as well. So this is a very common type of tube that we place in children to ventilate that ear space to prevent frequent ear infections or chronic ear infections. These typically stay in place for about 9 to 12 months before they get pushed out. That's an average. But as you can see, it's a very healthy eardrum behind it. There is some of that scarring there, which is probably the reason this patient wound up with a tube to begin with. By contrast, this is also a tube, but this is more of a quote-unquote permanent tube. And these can stay in until we take them out, or they can last years. And so this is for a patient or a child with really, really chronic problems who've required 3 or 4 sets of these more temporary tubes. So we'll move on a little bit to evaluation of the nasal cavity. This is an important tool that we use, rigid nasal endoscopy, for patients with complaints of pressure, obstruction, sinusitis in the nose, really any of those things. Again, a very brief office procedure. We do it on a high definition tower here to be able to photo document everything as well. Just by way of a quick anatomical lesson, we all have 4 pairs of sinuses. 2 in the cheek, maxillary sinuses, 2 in the forehead, frontal sinuses, and then these funny things called ethmoid sinuses between the eyes, and then sphenoid sinuses, which are a little further back. And I like this diagram even a little bit more because this shows the intimate relationship of the drainage pathway here from the maxillary sinus, which is this really narrow area here. And so what we're looking for is really any problems that would cause blockage of these relatively narrow sinus openings. So some patients may just be born with very small sinus openings, and a little bit of inflammation or allergy or cold can really block this and cause a lot of pressure or problems with sinusitis. And so that's what we're looking for. And also septal deviations or deviations of this middle part of the nose here, which we'll talk about in a little bit more. You can see that if this was just a little bit deviated over here, that would block this drainage pathway as well. And so this is pictures of just a very normal endoscopic view of the nose. So to orient you, this is what's called the inferior turbinate here. It's the same thing right here, middle turbinate. Turbinate just means nasal bone. Very nice and healthy, nice pink mucosa. nice airway to breathe through here. That's the black down there. This would be the sort of the back of the nose as you come down. So really very normal. And by contrast, here is what we see in quite pathologic noses. So these are both polyp problems in the nose, and polyps are really just excessive amounts of inflammation. I mean, they're bags of inflammation, basically, that block the nose, cause obstruction and pressure and pain. And so relatively large polyp here, a lot of edema or swelling. These tissues is red and angry tissue. This doesn't look like that nice normal pink mucosa we saw. And this is pus coming out of sinus, so this is an acute sinus infection here, and this allows us, when we use this tool, to be able to suction that out of there to clear a lot of the infection, and also to culture that if it's been unresponsive to antibiotics. These are even worse cases of polyp disease. This is really pretty bad. This patient really probably isn't breathing through the side of the nose at all, maybe through this little slit here, but really significant polypoid disease. And very similar here too. This is a little bit different in that this area is a little more flesh colored, and polyps really shouldn't be. And so this patient would need a biopsy to rule out a tumor or underlying growth in the nose as well. So deviated nasal septums, the septum is really just cartilage and bone which divides the nostrils in halves, and so this is a nice and normal one here. This is a deviated septum, and they can be mild, moderate, severe. You can be born with it. You can get a trauma to the nose. Doesn't take much to kind of deviate a septum, and this is a good example of one. This is what we call a big septal spur right here. So you can imagine that's really blocking that airway down there, as we saw from those normal pictures. So this patient probably isn't breathing very well through the side of the nose, and it's actually contacting that structure we call the inferior turbinate, and this contact point can be a big source of pain and pressure and headaches for patients actually as well. Moving on to laryngoscopy, or flexible fiber optic laryngoscopy, this allows us to see the voice box. So similar concept, just with a flexible tip, relatively easy in-office procedure through the nose. Here, we're able to see the voice box and the vocal cords and the associated structures. And the next video we'll show all is actually the dynamic view of this. What happens, and we have patients kind of phonate a little bit while we're doing it. You can go ahead and play it. So it gives us a really excellent view of these vocal cords and how they vibrate, and this is what creates voice. We want that nice wave of mucosa over these vocal cords to create good sound and a good voice. And when we have a patient sniff, the vocal cords come together, come apart, and so we can see if there's any vocal cord paralysis or anything like that, and that's very important. And obviously we can see if there's any abnormalities of the vocal cords as well. So these next few slides are actually just cases over the past few weeks of mine. This is a patient who was a smoker who came in with hoarseness, and we saw this big lesion here, which is obviously concerning. And under microscopic technique, we did a procedure to remove that in the OR. Same day surgery, very little pain, and this turned out to be high-grade dysplasia, which is basically the first form of cancer of the vocal cords. And so this is a curative procedure for him, and this mucosolizes or epithelializes very quickly, and this patient's voice will normalize very, very quickly. Similar concept here. This was moderate dysplasia, but just using microscopic technique, cut that area off and home by lunch with a better voice, typically with very little pain. This is a patient who was a singer and presented with a relatively abrupt onset of hoarseness, and when we looked down there, we saw this polyp here. And as you can remember from that video, this is right where those vocal cords should be coming together to create a nice vibration, and this polyp is obviously impeding that. And so we did a similar thing with him to just take that area off. It's a very benign polyp, but normalization of voice, in about an hour. So those are the kind of things that we see. This is kind of a different beast here. These are both fairly advanced laryngeal cancers, typically in smokers. This is a fairly higher stage, which really isn't treatable in the same way, and similar things here. So this patient is certainly going to be hoarse, may even have problems swallowing, and no breathing problems yet, but as you can imagine, if this would grow, this is going to start to block this airway a little bit more, which is obviously a very big problem. So we'll move on to just some really common otolaryngological problems that we see really on a daily basis. So probably some of you have had these things even. So we'll start with sinusitis and some of the associated problems, tonsil problems, and then transition over to hearing loss and ringing in the ears as we do our audiology portion. So sinusitis is classified as acute, chronic, or recurrent acute, basically, and we'll kind of focus on chronic, which is what we're probably most familiar with. Just chronic symptoms for 3 months or more, really not getting better in between. Acute is just an episode which resolves, basically. Recurrent acute is if you get 4 or more of these acute episodes in a year. And so inflammation is the key for sinusitis. There's inflammation all over in the sinuses, so we saw that with our endoscopic pictures. Here's a CT scan showing that as well. Very normal CT scan, nice black and open sinuses here, which are air filled here. Really nothing abnormal here. Completely the opposite. Totally opacified sinuses with gray. This is polyp disease. This patient is pretty miserable, can't breathe through their nose, and a lot of pressure and fullness in their face with and between their eyes as well. So here are the causes. They're basically the pathway of sinusitis. So we typically think about it as having problems with the anatomy, infectious problems, or allergy problems, all leading to inflammation. And so a lot of the medicines that we use block this inflammation down here, and that's helpful, but really we want to try to block it up here to treat the cause. What is making a patient have these problems to begin with? And so talking about anatomic problems, here's just a really easy view of a deviated nasal septum. You don't need much in the way of an endoscope to see this, a pretty significant septum coming out of the nose. This patient really isn't breathing through this side at all compared to the other side. And if this continues up, it can block that drainage pathway right up there. Similarly, that inferior turbinate can become a big problem as well. And so this is a normal one, nice big area to breathe through here, and this can become progressively swollen and inflamed. And this, this severe amount of enlargement here is completely blocking this patient's nose. And when it's this big, it creates a lot of inflammatory mucus with a lot of postnasal drainage. So that's another thing that we're very keen to look for. We do a lot of allergy testing in our clinic in treatment of allergy. And so this is simple and a quick office procedure, skin prick testing that we do with patients and even children sometimes. And so we're looking for this wheel and flare response when we apply a small amount of trees, grasses, weeds, pollens, danders, dust mite, any of those kind of things, and determine whether or not our medicine's going to cut it for this individual, or do we need to consider immunotherapy or allergy shots to desensitize their immune system. For patients that don't respond well to medical therapy, sinus surgery is sometimes considered. And so this is functional endoscopic sinus surgery, and that's to describe a very minimally invasive technique to treat sinus problems with no external incisions in the nose. And so this is kind of our setup here with high definition monitors and our endoscopes. And really we're aided with actually, I'll start here. This is just kind of a recent case. We did here. This is the cheek sinus. I hope that's coming up okay. A cheek sinus right here, and this is a big, super infected crust that patient had sitting in and infected with fungus and bacteria. And so we were able to get that out very nicely and easily. And the patient obviously didn't have that sensation of a kind of a rock sitting in their cheek with that, and their dental pain improved as well. This is what we want to see after a surgery. So. These are nice wide openings of this cheek or maxillary sinus and the ethmoid sinus here, and we want aeration and ventilation of those sinuses so that even if a patient gets sick or there's a little bit of swelling, this is going to remain nice and wide open to allow clearance of the mucus and debris in that sinus. So we're aided in a few technologies when we do these types of surgeries, and so the first one is image guidance that we use in almost every sinus surgery, and that's basically like GPS for the nose. And so this allows us in real time to point to a structure in the nose, and it will tell us where we are on a CT scan. And so that's really a very critical advancement in that we can really address areas that we want to specifically address and stay away from areas we really don't want to be near. And so that's been very helpful. And also balloon sinuplasty, probably that's a buzzword now as well, and that's a relatively newer sinus technique which we're using a decent amount of today, which is taking a page from cardiology and interventional procedures to be as minimally invasive as possible. And the concept is here to pressure dilate a little tiny opening with a balloon and relieve that pressure behind it through that mechanism. This is showing a guide wire in the frontal sinus here, indicating that we're in it, and then we would just advance a balloon and just dilate that tract and having release of pressure from that forehead sinus. Moving on to tonsil problems and pharyngeal issues. Tonsil problems are really an issue when they become too big or they get infected a lot. And so we actually take out a lot more tonsils these days because they're so big and impede breathing for a patient or lead to upper airway obstruction or sleep disordered problems. So these are just massive tonsils in the back of the throat. These are completely blocking airflow. This patient will have heroic snoring, which is basically you can hear it with the door closed, mouth breathing a lot, and maybe even some problems swallowing because of these guys back here. This is just a kind of exudative tonsillitis here. And this is kind of the other problem that we see a decent amount of, which is a peritonsillar abscess, which is kind of a really bad infection of the tonsil. This is pus pocket forming around the tonsil, causing this big amount of swelling back here with with a lot of problems. And so this can sometimes be treated with antibiotics, but sometimes this needs to be surgically drained, or if it is recurrent, have tonsils removed. Moving a little bit on to hearing loss as we transition over to audiology, and Dr. Auxier will talk a little bit about this as well, but we kind of break down the hearing loss depending on where it occurs, which isn't necessarily very critical, except that there's hearing loss that occur in the canal, if you have wax, in the middle part here, if you have fluid, or way back when it affects the nerve or the cochlea, which is the organ of hearing. And these tend to be, can happen for a lot of reasons, but what we think of as age-related hearing loss affecting the nerve. Otitis media, or fluid in the ear, is the most common cause of a conductive hearing loss. Sound just can't get where it wants to go. And so this is primarily a problem of a eustachian tube, which we'll touch on in just a slide or two here, but that airspace is not ventilated, or that middle ear space is not ventilated appropriately because of a bad eustachian tube. So we can treat this medically or surgically. And if it happens a lot, sometimes we consider tubes. So here's a little example of a tube, and what this does is bypass a dysfunctional eustachian tube. And so we create our own valve or opening in this eardrum to allow this fluid out and to get equalized with the external environment. And so we consider this in patients who have had 3 episodes of otitis media in 6 months, or 4 in 12 are the guidelines. Really persistent or chronic fluid that's remained behind the eardrum, or in kids who are at risk with speech delay, or what we consider kind of at-risk children here with cleft palate. Kids need a lot of repeat tubes because this eustachian tube just doesn't work very well. And so this eustachian tube here is dysfunctional in children because it's more horizontal compared to an adult, and it's floppy. It doesn't stay open very well compared to a relatively more normal pattern in an adult, and that can't create a very good drainage port for that middle ear space, which is why we have so many more problems. Adults can also have problems with it when they fly, when they get sick, when they have a sinus infection. This tube can just get swollen here. Adenoids are sometimes a problem in kids too, where it can block that little area back there. And occasionally, but rarely, tumors can cause problems with that tube as well. I think this is my last topic here, tinnitus, ringing in the ears, exceptionally common problem. About 40 million Americans here. This number may be outdated. We just heard more from like 60 or 70 potentially, but this is a noise that's created that really only the patient can hear. Chirping, white noise, crickets, ringing, buzzing, bells. There's a lot of descriptions of it, but it's generally associated with some type of hearing loss. Not everybody, but it's generally associated with some type of hearing loss, and it's really a sound generated by the brain or the central nervous system. And so that's an exceptionally difficult problem to treat, but as we'll kind of discuss a little bit, there are some over-the-counter things in behavioral therapy, and Dr. Auxier is actually our tinnitus specialist in clinic, and so we sometimes refer really tough cases of tinnitus to her, but hearing aids can also be helpful for some patients, and sometimes patients get relief with tinnitus that way as well. And I think that's it. And I think we'll save our questions to the end. Thank you very much.
All right, thank you, Dr. Nash and Holly. Thank you. All right, good morning. My name is Nicole Auxier. I'm one of the doctors of audiology. And just to save some time while I'm doing my presentation, I will be handing out some different styles of hearing aids that we do fit in our office. So I will pass those around so you guys can see that while I'm going through the presentation. All right. There we go. So again, like I said, I'm one of 4 audiologists, and my other partners include Dr. Elizabeth Gorman, Dr. Angela Egbrecht, and Dr. Leslie Moser. And what is an audiologist? An audiologist are professionals who diagnose, evaluate, manage individuals who have hearing loss, balance issues, and tinnitus. We have either a master's or a doctoral degree, and our team here at Agnesian are all doctors of audiology. We are certified by our national organization, the American Speech Language Hearing Association, and we are licensed by the state of Wisconsin. Our services include audiologic testing throughout the ages. We have electrophysiologic testing, tinnitus evaluation and management, hearing aid consultations and fittings. We also do repairs and services. We have hearing aid accessories such as remotes, Bluetooth devices, FM systems, and we also make custom earplugs for work or recreation. If a patient has significant wax buildup, ear infection, or a hearing loss that may be the result of a medical condition, or if we have any concerns based on the patient's history or test results, we do refer them to our ENT group for further evaluation and medical care. The first thing we do is we obtain a good case history, looking for any risk factors, medical conditions, or genetic causes for possible hearing loss, balance issues, or tinnitus. Then we look into the ears, looking for any wax, debris, or infection in the canal. Tympanometry, we use that to detect any fluid in the ears, especially with our kiddos, or any perforated eardrums or other medical conditions. Oh, sorry, not that one yet. Our acoustic reflexes and decay, they measure the two middle ear muscle contraction and strength in response to sound. Our comprehensive audiometry, we measure the degree and type of hearing loss that's present and a patient's speech understanding in quiet and in noise. This information will help determine if a patient needs to be seen by their physician or an ear, nose, and throat doctor, as many hearing loss patterns can correlate to certain medical conditions, such as Meniere's disease, otosclerosis, fluid, tumors, cardiovascular disease, and more. Or it helps us determine what type of treatment they need, such as if they're a hearing aid candidate. And then this is a picture of our audio booth and our tympanometer. Other more specialized testing we do includes DPOAEs, or distortion product otoacoustic emissions, that measures our outer hair cell function. We can actually measure changes in the outer hair cells before it shows up on a hearing test or an audiogram. And this is a useful tool for us to measure patients who've had noise exposure, are undergoing chemotherapy or radiation, in babies and in young children, and in patients with tinnitus. Our ABR is used to measure the hearing status in babies and in young children, in diagnosing auditory neuropathies, and in suspected cases where a tumor may be present. VNG or ENG, that's used to measure the peripheral and central pathways that may contribute to a patient's dizziness or vertigo. And finally, during our tinnitus management evaluation, I try to match a patient's tinnitus sound and measure the volume of that sound. We also measure if we can get the brain to what we call habituate, or decrease its reaction or the system's responsiveness to that sound. And then again, this is a picture of our VNG and ABR rooms. Some quick stats on hearing loss. There are over 30 million Americans with hearing loss, and the majority of those with hearing loss are younger than age 65 or under the age of retirement. And hearing loss can occur gradually. Hearing loss can also affect our quality of life and seriously impact our professional and personal lives, at times leading to isolation and withdrawal, impaired memory and ability to learn new tasks, reduced job performance and earning power, and diminished psychological and overall health. Some also common signs of hearing loss include word misunderstandings. Was that 33 or 43 when you were playing bingo? The TV is too loud, people are mumbling, and I can hear them but not understand them. Other signs include you're asking people to repeat more often. You're having a hard time understanding when you're in a background noise or party. You have ringing or roaring in your ears. It's harder to hear on the telephone. And you're often unsure of how to respond. You're uncomfortable, and you start to limit your conversations. So the effects of hearing loss, don't let it go untreated. Untreated people or adults report the following: sadness, depression, anxiety, decreased social activity. The family complains that they're being rude or aloof or talking too loud. Adults who've had their hearing loss treated report the following benefits: they have better relationships with their families, better feelings about themselves, improved mental health, and greater independence and security. Causes of hearing loss? Well, there's many possible causes. And since the ear has three parts, the outer, middle, and inner, the hearing loss can result in any of these areas. Other causes of noise exposure, probably one of the most common is noise exposure, aging, congenital or genetics, infections, head or ear trauma, and medications. Another is tumor or disease processes, such as Meniere's disease or auditory neuropathies. These causes are probably a little less known. Smoking disrupts the flow of blood and decreases the oxygen support to the inner ear. And hearing loss is twice as common in adults with diabetes. In heart disease, inadequate blood flow and trauma to the blood vessels to the inner ear can contribute to hearing loss. Patients with low frequency hearing loss should be regarded as at risk for cardiovascular events. Obesity can threaten the blood flow to the ear, and long-term alcohol abuse can damage the cochlear function, especially to our outer hair cells. How much hearing loss a person has is described as a range of normal, mild, moderate, moderately severe, and profound. We do not describe hearing loss as a percentage. And then this is a graph is another way to describe the degree of hearing loss through the speech sounds and other environmental sounds that a person is missing. Myths and facts. The hearing aid will block out what I don't want to hear. No. As advanced as hearing aids are today, they are just not smart enough to know who you want to hear or what you want to hear and what you don't. They are meant to amplify speech and try and make the ambient noises like fans, crowd noise, loud sounds, and traffic sounds more comfortable. Hearing in quieted environments and in complex environments will be improved, but it will not be like when we were 15. All types of hearing loss can be aided with either hearing aids, cochlear implants, or bone-anchored hearing aids. Hearing aids are actually more noticeable, hearing loss is more noticeable than actually a hearing aid. And digital hearing aids can be programmed to be automatic, where the hearing aid adjusts to the settings, or manual, where the listener adjusts the overall volume or the program settings. Research shows that wearing 2 hearing aids will give you many advantages, including hearing better in noise, getting a fuller sound, and better localization. Fitting the bad ear depends on the degree of loss in the word understanding. Some ears benefit from amplification, some do not. That's why Agnesian offers a 60-day trial period to see if we are getting benefit from amplifying the worst ear. And finally, hearing aids cannot bypass the amount of damage to our auditory system. It can only make the sounds audible enough for the brain to help make a better message. Hearing in noise, how do we do it? Our normal auditory system is able to detect and focus on speech, and it tunes out that unwanted noise. Our system automatically minimizes that annoyance, but a hearing impairment can disrupt this ability. And research shows that our ability to hear in background noises changes as early as our 30s. Our fitting process includes an initial evaluation and hearing aid discussion. We then order the hearing aids and the patient is fit about 2 weeks later. We have a 60-day trial period, and we see patients about every 2 or 3 weeks as needed for any adjustments before the patient decides if this is the right hearing aid for them. We then monitor the patient about every 6 months or sooner if they're having any concerns. And you guys have the box, so hopefully you get to see them. And here are some examples of hearing aids throughout history. So thank goodness we've come a long way. They're a lot nicer. There are many different styles of hearing aids, as you can see in that box. There are the in the ear to the behind the ear, and now to the even more popular receiver in the canal hearing aids. The factors. The right hearing aid for you depends on many factors, such as the degree of hearing loss, your technology needs, your ear shape and size, your ability to handle the instrument and the controls, and your lifestyle needs. Loss in technology. Your unique type and degree of hearing loss can dictate what type and style of hearing aid is best for you. You consult us, your audiologist, or in what type of technology is best for you. And we also look at your lifestyle. What activities do you do in a typical week? What is most affected by your hearing loss? Are there activities that you can't do because of the hearing loss? We evaluate your needs, your workplace considerations, your hobbies, your outdoor pursuits, and your travel. Handling, again, we're going back to the dexterity. Can you hold it? Can you see it? We adjust the size based on a lot of the dexterity issues. One ear versus two, the binaural advantage. Well, nature provides for two. God gave us 2 ears. We have improved detection of soft speech, especially when the source is not in front of us. We have increased intelligibility with 2 ears, as our brain receives the sound and speech from both ears, so it's easier for us to understand speech and noise. We get a stereo experience, where we have a fuller, more comfortable quality of sound and balance. And localization, sides matter. Research shows a higher level of satisfaction for those that wear 2 hearing aids. And there are many different levels of hearing aid technology. They range from entry-level digital hearing aids to the more advanced levels. If you think of hearing loss as an alphabet from A to Z, our entry-level digital hearing aids are probably will give you about J through N. And then as we flip to the next slide here, so again, hearing loss, going back to our alphabet analogy, hearing loss A to Z, entry level is about J through N. The more higher end digital will give us about, I would say about C to W. Again, hearing aids aren't perfect, but they're going to have a wider range of adjustments. Digital hearing aids will offer many benefits, including reducing or eliminating whistling, or what we call feedback. They minimize the phone interference. They help focus on amplification of speech while in a crowd. We have a wider range of adjustments with greater precision. We have more comfort in noise. And we also have wireless connectivity. The hearing aids now can have remotes. They can connect to Bluetooth devices and cell phones and TVs. The single most important factor in the process is the attitude and the commitment of the wearer and the development of realistic expectations. Hearing aids won't replicate the way you used to hear, nor will they restore or prevent further loss. But most people will gain significant improvement in their sense of hearing with hearing aids, though it is a gradual process that can and will take some time. Other realistic expectations. Patients who wear hearing aids for the first time commonly report it takes time to have something in your ear, takes time to adjusting to their own voice. They notice sounds before, like their squeaky floors in the kitchen, or their refrigerators humming, or the birds outside. Hearing aids can improve listening in noisy backgrounds, but hearing in complex environments is difficult for persons even with normal hearing. So remember, it takes time to adjust to the hearing sounds that you've been missing. The adjustment period, again, adjusting to a new hearing aid is an interactive process between you, your audiologist, and your loved ones. The initial and follow-up visits are essential to optimize the fine-tuning and peak performance. Most states offer a 30-day adjustment period. At Agnesian here, we offer a 60-day trial. Communication strategies are important for all of us working in healthcare, especially with our hard of hearing patients, as well as communicating with our family members and friends. For those with a hearing loss, some strategies include reducing the background noise before beginning a conversation and asking the speaker to rephrase instead of repeat what was said. Also, very important, look at the person so you can get more information about what's being said. And if you're still having troubles, be an advocate for yourself and tell that person how you need to hear better. So what can your loved ones do? Be encouraging, be patient, and be knowledgeable. The following strategies are especially helpful when you are working with patients with hearing loss in the clinic or the hospital, or when you're calling them on the phone for medication refills or appointments. You need to gain that person's attention, such as saying their name before starting talking. Make sure the listener can see your face clearly. Don't cover your mouth with your hand, or talk with your back turned. Number 2 is especially important when checking in our patients, and our computer screen is facing away from the patient. And again, rephrasing rather than repeating. Saying different words will help fill in further information and help them hear you better. Strategies for family members. Speak slowly and clearly without exaggerating your words. Use body language. That'll help them get the message if you're serious or if you're happy. Ask the listener if they understand you before continuing the conversation. Making sure they heard you can save you time and frustration. And if you have a patient who is having a hard time understanding either you or the physician, our Agnesian Health Shop has pocket talkers. And I didn't bring the headset here with us, but the pocket talkers are a personal amplifier, and family members will talk into the speaker while the patient is wearing the headset. And the patient has control of the volume or the tone, and then it also is going to help save your voice, because when you're talking into the speaker, you're not yelling at them. But the Agnesian Health Shop has these for sale or rent. And usually we recommend most departments should have this if you have patients, especially with hearing loss. So if you, a family member or friend, or a patient is struggling with hearing loss, balance concerns, or tinnitus, please hand them our information and contact our audiology department. We would love to help you. Thank you.
Thank you very much. Do we have questions for our doctors?
The pocket talker that you just showed, is that something that can be cleaned and reused for different patients?
What we actually use in our department is we get the little booties that fit over the headset, so that, the patient wears it, and then once they're done, we throw those away and put a new set of little headphone protectors on them.
Okay, so the little booties are also sold at the health shop?
And if not, we can get them too, through our department.
Wonderful, thank you.
Thank you for a great presentation. You did have the time to talk a lot about preventative things for hearing loss, and I think people don't realize the chronic exposure to noise and wearing ear protection, like when they're mowing the lawn and all of that. And kids with these, I'm wondering if you're seeing more hearing loss with these earbuds that everybody has, and when you walk by people, you can hear the music that's piping into their ears. How do we get education out and help people prevent that hearing loss, and how much hearing loss are you seeing from those headsets or those earphones that everybody's wearing?
I see some. However, I would say that not a lot of the teenage population is coming in unless the parents are noticing it or that's impacting the education and the teachers. They have programs through our educational audiology departments that the schools should be getting them to know. There's different programs online too called Turn Your Buds Down. So basically what we counsel when patients come in, or the younger ones, is that if mom and dad can hear you within 3 feet away, it's too loud, you gotta turn it down. And especially for the kids that we have come in, we have little foam earplugs that we will hand out, and I forgot to rephrase the question, sorry, that was my fault. Even my children, I have the circumaural headphones, so when we go to EAA or when daddy's mowing the lawn, we're like Drew Brees and his kid at the Super Bowl, we have our headsets on, so I'm training them from little on. So hopefully it's getting into the schools, and if not, we counsel them when they come in for our appointments. It's essential, because once that noise exposure hits, the hearing's gone.
Hi, when you have a young child that is possibly speech delayed and you're doing hearing tests, how do you know at that age when they're 2 or younger that they're actually hearing, because they can't raise their hand saying, yes, I can hear on this side, or yes? What do you do to see if their hearing is intact?
So for our question on how we test the little ones, say they're 2 or under, since they don't really get, when you hear the beep, raise your hand, we do a lot of things in the booth. So the first thing, again, is seeing if they have any wax or fluid in the ears. And if we do our tympanometry and they've got wax or fluid behind the eardrums, again, we're going to be referring them back to their primary care physician, pediatrician, ear, nose, and throat if it's chronic. And then what we do too in the booth is we use sound field. So we have the child sitting on mom and dad's lap, we have speakers on the side, and if they can tolerate headphones and we play different sounds and they turn, or we look for behavioral, like, they're hearing something, so we can kind of get an estimate of hearing loss that way, if there is any. And then the otoacoustic emissions help us know if the outer hair cells are functioning too. And then more specifically, you have further testing too if we need to do CT scans or anything.
Right. So, yeah, if there's a documented hearing loss, like you said, OAEs can be helpful, or these ABRs or auditory brainstem responses, which give you an idea. It's kind of like an EEG for the hearing system that can be applied. That can be very helpful, but if there's hearing loss or we're worried about hearing contributing to speech delay, then there's further workup, imaging or MRIs or CAT scans to look at the ears a little bit more closely to determine why that might be the case.
Does that answer your question? Okay.
How do you know, are we allowed to just come to see the audiologist, or do we need a referral from our MD?
Good question. So how do you see us? So most insurances, if you are under the age of retirement, we still recommend that you check with your insurance. Most insurances will let you see us directly. However, Medicare, medical assistance, and as we get older, then we need a physician's referral to come see us to do further testing. So that's a good question. Oh, I should also add too, for Agnesian employees and volunteers, we do offer a 25% discount on our hearing aids, pending your insurance. So that's also a nice benefit Agnesian offers.
Back in the day, it seemed like my classmates and I all took turns going to the hospital to get our tonsils removed. And then as I had children, that really wasn't an option. Did have the standards changed? Are kids healthier, or were we too quick back in the 70s to take out tonsils?
That's a great question. So the question is, when do we take out tonsils, and are we doing it as much as we used to? And what that's really getting at is the paradigm has really shifted for when we do tonsillectomy, and just probably as little as 15 or 10 years ago even, the vast majority of tonsils were taken out for repeat infections, and so that criteria wasn't really established then. The vast majority today is for breathing problems, and so we don't take tonsils out for 1 or 2 or 3 strep infections like historically that may have been done. Today it really requires a great deal of infections to take them out, and again that's a very uncommon reason today compared to the obstructive breathing pattern, and very simply that wasn't probably recognized maybe as much as it is today as a really a problem going forward. When a child has sleep disorder or obstructive breathing patterns, that can be a really big problem in adulthood, and that's something we're probably much more aware of today, and so that's why typically that paradigm has shifted a little bit. Does that answer your question?
I have a question. So sinus rinse, is that a good idea, or is that the risk of infection greater than the potential benefit?
So the question is about saline rinses or sinus irrigations, and so they're a good idea. They help a lot. Studies have all shown that they're very effective, and you just have to use distilled water in it, so just not tap water. It has to be antiseptic, or it has to be at least be distilled or boiled typically, and that risk of creating an infection with it is very minimal. It creates a very inhospitable atmosphere in your nose for something to grow with that saline and that hypertonic solution. Bacteria and fungus don't like that, and it flushes a lot of it away, and that's the mechanism through which that helps.
What about Q-tips? You mentioned those a couple of
Q-tips
times.
are bad, yeah. Yeah, that's, a lot of my patients say they were always told not to put anything bigger than their elbow or their hand in their ear, or anything smaller than their elbow or their hand in their ear, and that's really true. I mean, Q-tips do nothing but cause problems, and wax is good, a little bit is good. It's antibacterial, and it serves to lubricate the ear canal and prevent itching and all those kind of things, and the more patients use Q-tips, those small things can happen, but then more serious problems, bad ear infections, and even eardrum perforations. We see a decent amount where someone's in the bathroom using it, and then someone opens the door and their ear gets hit, and the Q-tip goes in, or the whole Q-tip doesn't come out, and so those are, can be obviously problems.
Stay away from the Q-tips.
Yeah.
Ear candling, can you weigh in on that? Is that a good idea?
Ear candling. So the question is ear candling good or bad? We're fairly neutral about it. I would say we've seen some problems with it. I think a lot of patients do it and seem to be okay with it. I think more than anything, if you have a really severe wax impaction, it's probably not going to touch it, and it's probably just really not doing a whole lot. And there can be some people use it wrong and can cause actually some thermal damage in their ear. But the bottom line is that it probably isn't helping a whole lot with severe wax impactions to begin with.
Is there any problem with using the nasal bands to decrease snoring over time, the ones that kind of spread your nares?
So the question is about breathe right strips, basically, and they're great. They're wonderful. They're really, really helpful. I mean, football players use them to increase the amount of air going through the nose, and in some ways, it's what we do surgically. We try to create a wider opening like that, so they can be very helpful. And I never discourage a patient from using it. The two just problems with it are that the adhesive is really strong, and so every day at night pulling that off, we get a lot of patients with just really continual irritation from that, and they can be a little pricey if you're going to use them every day. But other than that, there's really no problem with them, and they do a fairly good job of sort of opening that angle up and allowing more air passage. So I don't discourage them.
Excellent. Thank you so much. What a great
Thank you very
presentation.
much.